They're very well behaved, aren't they? Good, okay. Good afternoon. As most of you know, I'm Amy Donnelly, and on behalf of the UCO's Department of Sociology, it is my privilege to welcome you all here today, introduce our guest speaker, Dr. Adia Harvey Wingfield. Professor Wingfield is the Mary Tilliston Hemingway Professor of Arts and Sciences and Vice Dean for Faculty Development and Diversity at Washington University in St. Louis. Her research examines how and why racial and gender inequality persists in professional occupations. Professor Wingfield has lectured internationally on her research in this area, and her work has been published in numerous peer-reviewed journals, including Annual Review of Sociology, Gender and Society, and the American Sociological Review. She has served as president of both Sociologists for Women in Society and the Southern Sociological Society, and is an elected member of the Sociological Research Association. In addition to her academic scholarship, Professor Wingfield writes regularly for mainstream outlets, including Slate, The Atlantic, Vox, and Harvard Business Review. She's the recipient of multiple awards, including the 2013 Richard A. Lester Award from Princeton University for her book, No More Invisible Man, Race and Gender in Men's Work, the 2018 Public Understanding of Sociology Award from the American Sociological Association, and the 2019 C. Wright Mills Award from the Society for the Study of Social Problems for her most recent book, Flatlining Race, Work, and Healthcare in the New Economy. Today, she will be speaking with us on what happens to Black professionals when work transforms. In an era of rapid technological change, shrinking protections for workers, and growing income inequality, work is no longer the secure, stable, predictable path to economic stability that it once was. At the same time, many organizations also profess an interest in meeting the needs of an increasingly diverse population. How do they manage the tensions of adapting to these neoliberal ideals in a multiracial society? Today, Dr. Wingfield will be answering this question. So join me in welcoming Professor Adia Harvey Wingfield. Thank you.
Thank you so much for that introduction, and thanks everybody for your willingness to attend today. So as Amy mentioned, my research focuses on racial and gender inequality in the professions, and most of my work has tried to address issues and topics related to those experiences, so looking at Black workers in environments where they are in the minority and trying to understand better what types of challenges and opportunities and obstacles they face in those contexts. So as I mentioned, the title of my presentation today is Professional Work in a Post-Racial Era, Black Healthcare Workers in the New Economy. And in order to apply some of that broader analysis to this topic, what I actually wanted to do is to take a step back and think a little bit about what work used to look like to give us some context for what work looks like today to make sense of what that means for Black workers. So if we think about what work used to look like, there's often this idealized depiction that we have of the post-World War II work world. And this is a time period where work was pretty widely available to many people. People were likely to work for one company for the duration of their careers. Workers had a pretty good amount of job security, and there wasn't a lot of turnover and transition of people moving from place to place. Workplaces also offered fairly competitive benefits in the sense that people could rely on pretty robust health insurance plans, some retirement insurance, and count that as just part of the experience of having the job. And organizations had a fairly robust middle management sector where people could count on, or at least expect to some degree, for there to be layers above them in an organizational structure that if they were motivated to try to pursue leadership, it was at least realistic to expect that there might be opportunities to pursue leadership at that organization. Now, it's also important to point out that when we look at this model of work, this is pretty reliant on occupational segregation. This isn't a workplace model that was available to women of all races, to workers of color. And it also is a workplace model that was largely subsidized by having a fairly robust public sector. So this is a workplace environment where training and grants in terms of providing support for training and credentials offered ways for people to offset the costs associated with going to school or getting advanced degrees and getting training, additional training and so forth. So when we look at what work looks like today, we get a pretty different picture. And it's a picture that's not quite as robust and rosy as the picture of work of yesteryear. Today we know that workers are facing declining unionization, where workers in the public sector are less likely to be unionized, and unionization in the private sector is even lower than earlier numbers. Workers experience much less job security. That idea that people can work at one company for the duration of their career is not really quite as accurate as it was. People are more likely to bounce around and move into different positions than they were in previous eras. You can categorize this as saying that workers are experiencing more autonomy and self-direction, but ultimately it is a case of workers taking on more steps to pursue their own occupational paths and less likely for that to be structured by the organization itself. Organizations are also flatter, and workers take on much more responsibility for their benefits than they did in previous eras. So this model of organizations providing, again, a retirement benefit or a retirement pension where you can be guaranteed to work for a place for 20 years and retire pretty comfortably based on that work. It's not really what happens anymore. Today, you're likely, if you have a position that offers some sort of insurance or benefit, to contribute more and more of your own salary and income to that benefit of retirement, and that's if you work in a position where retirement is even offered in the first place. There's also more stated support for diversity in many organizations, and there's more discussion about this being something that organizations are committed to and something that they value and find important. But overall, the research shows that we are likely to see a much more frayed contract between organizations and employees than we have in previous eras. And researchers show that this has contributed to more economic and more emotional uncertainty as many workers try to figure out how to navigate this environment where they aren't necessarily guaranteed the same opportunities, protections, and stabilities as they would have had in previous eras. So in this context, it's useful to think about the new economy as an example of what work looks like today or what the economy looks like today. But it's also important to note that amidst this uncertainty, professional work remains one of few routes to economic security that exists today. And professional occupations benefit from technological advances, from the growth of the knowledge economy, and they're also a lot more likely to be the focus of diversity dialogue, and that you hear a lot more discussion among professional occupations or among organizations that are focusing on the professional jobs within about the importance of having more diversity and how that's more valuable in those jobs. So what I wanted to do with this project was to think about what this new economy means for Black professionals. As people who are navigating an environment where work has shifted dramatically from what it was in previous eras, and where diversity is more likely to be part of the discussion, but professional work itself is more scarce and the routes to professional work have become a little bit more uncertain, how are Black professionals navigating those transitions, and what are they doing in that environment? So there are some existing theories that give us some insights into what we might expect to find in conducting this research. My colleagues George Wilson, Vinny Rossino, and Matt Huffman have done extensive work looking at what happens as the public sector becomes increasingly privatized. And what they found has been that increasing downward mobility has been the consequence, particularly for Black workers. And so what they show is that as as functions that used to be primarily the province of public sector initiatives and companies have increasingly privatized, that privatization has meant a drop in employment and opportunities for Black workers, especially Black men, who were disproportionately employed in public sector work. We also know from the work of Sharon Collins and Frank Dobbin that organizations have largely failed at their attempts at increasing more diversity, particularly racial and gender diversity, and that if we look at the top levels of organizations, a lot of that diversity that organizations say that they value isn't really quite so present. And finally, my colleague at WashU, Jake Rosenfeld, has shown that declining unionization has served to exacerbate racial wage inequality. That as the numbers of union members have dwindled over time, that has had consequences for racial wage inequality by serving to perpetuate it. So this work is useful because it gives us some insights into what we might expect to find for this changing work landscape for Black professionals. We might expect to find that, for example, as the public sector has become increasingly privatized, these Black workers are perhaps looking for more private sector opportunities. We might expect to find that workers are more disillusioned by failed attempts at diversity, or we might expect to find that workers are frustrated by the decline in unionization and what that means for perpetuating racial wage inequality as it persists in some occupations. But I think that this work also leaves unanswered some questions about how Black professionals are dealing with that work transformation, right? We don't necessarily know if the public sector remains as attractive even as it's become increasingly privatized. And we don't necessarily know if the failed attempts for more diversity have led to a decrease and a drop-off in support for policies that are designed to focus on or improve that area. So it strikes me that there's still, or it struck me during this research, that even while we know a good bit about the structural causes that have an impact on Black professional workers, we don't quite know how those workers are responding to those structural factors and how they are dealing with this decline in unionization, the lack of supports around diversity, or the failed attempts to create more diversity, or what this means to see more privatization happening. So these give rise to the core questions that I will focus on in this project and that frame the presentation that I'll talk about, that frame the work that I'll be discussing today. The core questions I wanted to focus on for this project were to think about what the new economy means for Black workers who are doing professional work and how they're navigating, as I mentioned, that uncertain environment. As many industries in the new economy become more privatized, more stratified, and more unequal, where and how do Black professionals fall? What are their challenges? What are their opportunities? Who's winning and who's losing as we are seeing these larger economic and to some degree cultural shifts happening that are reshaping the world that we work in today? So in thinking through this project, it struck me that the healthcare industry actually offered a really useful site for trying to address and answer some of these questions. And the reason I say that is that when we think about how work and the economy and occupations are shifting, healthcare actually offers an industry where all of these transformations are happening kind of in one place in a site that's actually really, really ripe for study. For one thing, when we think about the increasing privatization of public industries or public services, healthcare has certainly been subject to this in a way that I argue emerges as a tiered system of healthcare, where there is a private system where well-off, healthy, quote, responsible patients are able to access private facilities, use private insurance, and get the best care that they can pay for. And then there is a public system where there is minimally funded public sector care that's available to everybody else. So at the same time that we are seeing this tiered system of healthcare emerge, where there is this public and private system, we are also seeing this occur in tandem with changes to U.S. racial demographics. So as organizations and industries are talking more about the importance of diversity, they are also doing so at a time where healthcare in particular is becoming increasingly privatized in ways that don't necessarily reflect the increasingly diverse demographics of the population that healthcare facilities are continuing to serve. And at the same time, this increasing privatization and these changes in healthcare occur as routes to professional work have become less stable. So as we are seeing students taking on more debt, for an example, in part as a consequence of the shortcoming in terms of public resources and support for education, we're also seeing that that has implications for how people get trained to take on the very time-consuming and financially heavy work of becoming trained to become a doctor, to become a nurse, right? Those shifts in public services and those shifts in how people access professional work mean that those routes to accessing these professional jobs have become a lot narrower and harder to access, again, at the same time that our population has become more diverse. So all of these broader factors that I described that are creating these economic shifts, increasing privatization, what that privatization means for routes to professional work, this discussion around and attention to racial diversity. These are all things that are happening in healthcare and that the industry has been trying to reckon with in varying ways that we'll talk about shortly. I'm not sure how visible that is. That print is larger on my computer than it looks here on the screen. But if you're having a hard time reading it, essentially this is just some demographic data to show where Black workers are represented in different jobs in the healthcare industry. It may not surprise anyone to see that Black workers are least represented among the physician population, where they are 5%. They are underrepresented as well as EMTs and paramedics and as physician assistants. We start to see more representation among some forms of technical work, such as diagnostic-related technicians. They are almost at parity when it comes to their presence among registered nurses. And Black workers are actually slightly overrepresented as health practitioner support techs and medical and clinical lab techs, and more overrepresented as medical record technicians and very overrepresented as licensed practical nurses. The thing to keep in mind here, though, is that when we think about healthcare as an industry, these representations are also tied to the types of jobs in healthcare work that are hardest to access and pay the most, right? So if you're talking about being a doctor, clearly among the occupations that I listed here, this is the most high status profession, it pays the most, it's also where we see Black workers least represented. If we were talking about technical work, these are the jobs that are easier to get into relative from a training standpoint. They are the jobs that pay less, offer less status, less prestige, and less control and autonomy over the jobs done. So there's an inverse relationship between the highest status, most well-paying, and most prestigious positions in healthcare and where Black workers are represented. So what I want to focus on for the remainder of this presentation is to narrow down a bit the core question that guides this into a specific aspect of work transformation. I focus in the book that this is based on, Flatlining, on how work transformation in the new economy affects Black professionals broadly. What I'll focus on here is what that means when it comes to diversity ideology, which is an aspect of how we have seen organizations and industries change. There is more focus, and you're more likely to hear many organizations and many industries now say that diversity is something that they value, and it's something that's important to them, and it's something that they want to achieve. This is particularly present in medicine and nursing, where the professional associations associated with both of these occupations, you can look on their websites and it's front and center that this is something we value. We want to see a more diverse nursing workforce. We want to see more diversity among our physician population. What I'll talk about for the rest of this presentation is the impact that this change has on Black professionals, again, especially in an environment where we also know that they are contextualized in a new economy where these shifts towards professional work are changing and where organizations are not necessarily devoting the same resources to achieving these ends. So in order to conduct this research, I engaged in intensive semi-structured interviews with 75 healthcare workers. These workers were doctors, nurses, physician assistants, and technicians. And generally, I spent between 1 to 2 hours talking to these healthcare workers to try to get a better understanding of their work and their experiences, what challenges they faced, how they felt about a lot of the new shifts and changes that are happening in healthcare, what their responses were to those, and so forth. I was also able to use some data from the American Panel Survey, which is a survey that WashU administers quarterly to a representative sample of 2,000 adults. And I put some questions on there just to try to incorporate a bit of a mixed methods approach and get some data from that. And finally, I did field observations in 3 settings. I spent some time actually shadowing some healthcare workers to get a sense of what their work looked like on a day-to-day basis on the ground level. So I spent time with a Black woman who was a pediatrician in a private practice, a Black woman who was an OBGYN at a research and university hospital, and then a Black man who was an emergency medicine doctor at a public facility. And again, the idea there was just to try to get more of a firsthand sense of their work in these different organizational settings, but also to see how it juxtaposed or confirmed what they were telling me in the interview process. So, on to the findings. What I found in talking with all of these workers, or with these workers more generally, is that perhaps counterintuitively, from a lot of Black healthcare workers, I found that diversity initiatives left Black professionals feeling apathetic, indifferent, and in some cases even annoyed. And this wasn't because they didn't support these initiatives. It wasn't that they didn't believe in diversity, or they felt like it didn't matter, it was a waste of their time, or that time was past, or anything like that. What I did find was that for many healthcare workers who were Black, diversity efforts did not reflect their racial work experiences. They experienced a significant disconnect between the types of initiatives that were present in their workplaces and what they actually were experiencing on the ground as people who were in these environments. This divergence varied pretty significantly by occupational status, and it also differed in some interesting ways by gender as well. So I'll start with doctors. And when I spoke with Black doctors and asked them what types of initiatives, if any, they were subject to at work and how their workplaces tried to, whether and how their workplaces tried to enforce this idea that they were committed to diversity, they told me that the most common initiative in place was that they had to complete cultural competence trainings. They were not in favor of cultural competence trainings. In most cases, many Black workers viewed these as unnecessary bureaucratic hurdles. This was yet another thing that they had to do with their day that they felt detracted from the practice of medicine. But interestingly, for many Black healthcare workers, they also said that these cultural competence trainings were disconnected from the ways that they felt that race affected their work. And so when I asked them to tell me more about what that looked like, they told me that it was not an experience where they encountered overt, everyday racial aggressions. It was not an experience where they go to work and feel like every day someone's hassling me, or I'm having problems, or people are rude, or there are micro or macro aggressions. Instead, they were a lot more likely to say that race affected them through structural and cultural processes. And with race embedded in these structural avenues, gender actually became a much more obvious form of overt bias, particularly for Black women working as physicians. Okay, here's some quotes to this effect. This is a quote from Randy, an emergency medicine doctor that I spoke with, and I asked him what he thought about the types of diversity initiatives present in his hospital, and he actually rolled his eyes and told me, "It's the right idea, but that stuff doesn't mean anything. Nobody takes it seriously. Obviously, I think more diversity is important. It's necessary, but the way they do it, the trainings and modules, it's just one more box to check. They just want quick fixes. Doing the hard work, really changing the profession to get more Black and brown people in here, that's not sexy." And I include this quote because I heard some iteration of this from many of my respondents, this idea that they were being forced to engage in these trainings and that these trainings really were pretty much a waste of their time. They did not seem construed to doing what many of my respondents felt was the more systematic and larger scale work of actually transforming healthcare, of figuring out how to get more Black doctors into the field, of looking at the barriers that keep more Black doctors out of the field. None of that is encapsulated in cultural competence trainings. And as a result, there wasn't really a lot of interest in or support for having to spend part of one's day going through this training module because it just seems so disconnected from the reality of their work lives. This is a quote that I include from Allison, who is a geneticist. And I include this quote from Allison because she was telling me more about how she felt that race did have an impact on her work. So when I talk about how Black healthcare workers feel that these cultural competence trainings are not connected to what they experience, Allison's work gives some interesting insights into what these experiences look like. And so when I asked her to tell me whether and how race had an effect on her work, she told me, "It's impacted my work just because my interests are focused more so on health disparities, medically underserved populations, minorities, those who often do not know about genetic resources or genetic services that are available. And I find it difficult to identify mentors or people who are familiar with those populations, people who are also passionate about educating those populations about genetic services or resources. So I have not really had much luck identifying people who are working with those populations who can help me better address some of the needs or some of the disparities that I see." So I include this point because this underscores what I heard from a lot of respondents about the ways that when they thought about how race impacted their work, it wasn't, again, this experience for doctors of this overt harassment or marginality, right? You can see from Allison's quote that for her, the bigger challenge in navigating her workspace is this feeling that she doesn't have access to mentors who are focused on reducing racial health disparities. And this is particularly important when we think about the context of this work in the new economy, where relationships and having access to mentors and having access to people who can guide your career trajectory can really become very critical for mobility, for finding jobs, for moving ahead in jobs, particularly as organizations have shifted away from an earlier model where people simply worked in one place and were able to experience some mobility upwards through the ranks of that particular organization. So Allison being in this environment, in this setting where she's kind of adrift and feeling as if she doesn't have access to mentors who can help her focus on racial disparity, for her, this is a bigger problem. And this is a salient issue that, again, these cultural competence trainings aren't designed to fix and aren't really addressing. Now, I have this next quote from Edgar because I don't want to give the impression that for Black doctors, there never were experiences where they did encounter more overt forms of racial bias or racial issues. And so Edgar gives me the example of what I refer to in the book as the that one time experience. And most doctors would say, well, there was that one time when something weird happened, I didn't like it, this person was super inappropriate, and I didn't quite know how to respond. But typically, that has not been my issue. My issues have been more structural in terms of not having access to mentors, like Allison told us. So Edgar told me, so I can think of one time when I was working in the ER, and God bless him, there was a fellow who came in who was pissed drunk, having chest pains, had no insurance. I'm the only one manning the ER. He comes in and decides he wasn't going to let no N-word doctor take care of him, so he fixed me by getting up and walking out. That was beyond my control. That was his cultural bias that basically put his life on the line. It's extremely rare for me. I think that may have been one of only 2 experiences that I've had in 30-something years of white patients that were negative. So again, this is an important point because it offers some context to what Black workers are experiencing in these spaces. It is not that experiences like these never happen, but for Black doctors, they are infrequent and rare enough that the more structural barriers that they encounter, like Allison's, take on a lot more significance as being the more impactful problems that they have to deal with and that they have to encounter. There's a gender dynamic to this as well, which I'll illustrate here with this quote from Aisha. And what I found was that for many Black women doctors, because those experiences of dealing with racial bias were so structural and so embedded into the structure of their work lives, this meant that the much more overt experiences that they had with gender inequality, with sexism, with patients' and colleagues' assumptions, took center stage and seemed much more salient and much more significant. And the quote from Aisha attests to this. Aisha is a neonatologist who told me, because I see my coworkers that are males and the race doesn't matter. If you're male, they will call you a doctor. If you're female, they will call you a nurse. But it's regardless of your race. Like I see my white coworkers, even just because they're female, they still call them nurse. If they're male, they're a doctor. If they're female, they're a nurse. But the race doesn't really matter. It's the male versus female. That's more important than the race. So again, for many Black women doctors, an interesting dynamic that emerged in the interviews was that I would ask them to let me know if they felt that race had an impact on their work, and if so, how. And almost to a point, every single one of them pivoted and would say, well, you know, as a woman or as a Black woman doctor, my issue and my challenge is people don't take me seriously, or people are always calling me the nurse, or my colleagues think that I am going to quit and have a baby in a year because that's just what women do. There was a much more consistent experience with this overt gender bias because the racial dynamics were more structural. But ultimately, what came through from the data were that for so many of these Black workers who were physicians, the types of initiatives that organizations put into place looked over all of that. None of these issues, none of the structural challenges that workers like Allison experienced, none of the gender-based issues that workers like Aisha experienced, none of the infrequent experiences with overt racism like Edgar described. None of those things were present in the types of initiatives that organizations put forth to try to address race. So even in as much as organizations talk more about wanting to have more attention to diversity, for Black physicians, that still misses the realities of the experiences that they have in these workplaces and explains why they were more jaded and more cynical about the efficacy of these attempts. So I'll turn now to Black nurses who gave very different responses than what I heard from Black doctors. Black nurses were more likely to tell me that they worked in institutions that claimed to be diverse places, but they felt that these claims were usually not reflected in their interactions. Unlike doctors, nurses routinely described explicitly racist exchanges with their white colleagues. But like doctors, they also were more likely to observe structural processes that disadvantaged Black nurses. But because nurses experienced these overt experiences in their interactions, as well as these structural dynamics that created difficulties for them in their work, they were a lot more likely to be mistrustful of of diversity rhetoric due to the different racial realities of their work. Whereas doctors were, I think, more inclined to think that their organizations meant well but were executing poorly, nurses did not give their organizations the benefit of the doubt. They did not think that their organizations meant well. They felt that pretty much the initiatives put in place were simply verbal proclamations or written proclamations designed to avoid lawsuits and that were not genuinely motivated by wanting to make sure that they as nurses were protected. And a lot of this had to do with the experiences that they had, which I'll describe now. So Stephen is an orthopedic nurse, and he was one of the nurses who described a lot of skepticism about what organizations say versus what they actually do. He told me, when you look at the settings, the more people say that they're diverse, the more that they are not diverse. They're diverse on paper because you have to be. But if you're diverse on paper, you ought to be diverse in practice. One cannot go without the other. And when I say that to mean that when you're stating that you are a diverse program, your nursing staff should reflect that. I know one school where in the fall of 2011, they admitted 50 students into the nursing program and none of them were African American. So that was not very representative of what their mission is. So again, Stephen is pretty clear that from what he sees in the organizations where he works, the focus on diversity in nursing is much more about making a statement. This is something we believe in, we support diversity, we care about it, it matters, we value it. But again, when he looks at what actually happens in practice, there's a lot of disconnect between those statements and the realities of his work. This is a quote from Janet, who is a pediatric nurse. And I include this quote from Janet because she underscores some of the structural barriers that many nurses were likely to identify in the profession that inhibited the opportunities for Black workers. Janet told me, the push is to have all nurses, the entry level, be a Bachelor of Science in nursing and not community college or diploma programs. So those nurses who do attend community college or diploma programs actually may find that they struggle a little bit more to obtain a job than those with a bachelor's degree. How many Black nurses go to community colleges because the tuition is less expensive, or maybe it's a little bit easier to get into a program in terms of just the numbers of people that they accept, or the feasibility of having a family and going to a community college? So a point that Janet is making here, I think, again, is useful and instructive to consider when we talk about the new economy and how work is shifting and changing. Nursing in particular is a field that I think is undergoing some professionalization, and we see some of that evidenced in the heightened expectations for educational attainment for nurses that Janet is describing. But what she's also pointing to is that as organizations try to up these standards and up their expectations for educational attainment, perhaps inadvertently that can have consequences for Black workers who are interested in the profession that end up creating structural barriers for them, whether there is more convenience in a community college, whether there's more of a challenge in attending the four-year program. Ultimately, this particular shift of expecting more credentials and more training and shifting the process by which people are able to access those credentialing and trainings, those credentials and training, when there's not also commensurate support for people who are interested in pursuing higher education, means that Black workers are disproportionately more likely to bear the consequences of this. And this is the point that Janet is making, that while we see this particular profession shifting in this direction, this shift ultimately means that Black workers are dealing with these consequences. But again, there's not attention from the organization to try to think through what that means for actually creating more diversity for Black nurses. And this becomes an example of the types of structural challenges that Black nurses point out. This final quote from nurses that I'll include is from Mindy, who's a mother-baby nurse. And this is rather a stark example of some of the more interpersonal challenges that nurses dealt with as well. And Mindy told me upon moving into intensive care where she was before becoming a mother-baby nurse, she dealt with a lot of challenges from her colleagues. And so when I asked her to elaborate, she said, I was just kind of noticing that there was just kind of this demeanor of how dare you be in intensive care because of your race. It never starts out as things that they say right out. They start, some nurses, some white nurses, will kind of not say anything, but just kind of They don't come right out and say it. It's the way that they look at you when you notice these subtle differences. But long story short, someone actually said to me, we were talking about after work getting together, hanging out, and said, oh, you can come to my house, but you'd have to be carrying a pail and wearing a rag on your head to come to my home. So this very overt suggestion that Mindy is only welcome in a coworker's house if she's there to clean it in a domestic capacity, this wasn't an isolated incident for Mindy. So whereas doctors were more likely to say, well, there was that one time when this thing happened that, I was uncomfortable with, nurses were more likely to say something like, how much time do we have for this interview? Because just yesterday, my charge nurse said this awful thing. And then 2 weeks ago, my other coworker said something really terrible. And then before that, I had this other situation with another colleague. And even in Mindy's case, this was one of many examples that she gave me with many coworkers with experiences like this. This wasn't the one-off, right? And so again, I introduced this quote to make this point that for Black nurses, given that these types of experiences were regular, these were routine, these were commonplaces, and commonplace, not commonplaces, these were commonplace experiences, and given that the organizations where they were employed didn't really seem to do much about it, nor did they try to address the structural barriers that kept the numbers of Black nurses low in the first place, it became really difficult for Black nurses to be supportive of the types of initiatives that the organizations had in place, especially when those initiatives seemed to simply be limited to offering some lip service, but not really addressing incidents and situations like these. Okay. So I'll turn now to Black technicians, who are an interesting case. And they're interesting, ironically, because they actually were the most hopeful about diversity initiatives. And this is ironic for a couple of reasons. It's ironic because their hope did not stem from an expectation or a belief that they were going to necessarily be helped by these types of initiatives. And this is supported by research that suggests that diversity rhetoric is rarely applied to lower status workers. They were not, and they recognize that they were not in the category for whom diversity work is typically directed and the focus. But Black technicians were actually very hopeful that they still would see some gains, or that there still would be gains in present from having these initiatives in place. What they felt was that existing diversity policies that they observed were not going to probably do much to address the hostile racial interactions that they often had with patients and with nurses who were situated above them in the organizational hierarchy. But they were hopeful because they believed that these types of initiatives might help nurses and doctors treat patients of color more effectively. So whereas technicians were the people, one, who had the most distance from these types of diversity initiatives and who were the least likely to be directly affected by and impacted by these diversity initiatives, they actually were also the people who were the most hopeful about their potential for change and success. And the reason for that was because they felt that even if they weren't directly going to be impacted by them, there was benefit to having doctors and nurses go through whatever procedures that they went through to help make them be more able to effectively treat patients of color who came through their facilities. Here's a quote from Amber, a cardiac monitor technician, and she attests to this. And when I asked Amber what she thought about the initiative, whether there were initiatives in place, and if so, what she thought about them, she told me, I don't think that it'll impact the work that I do just because of my minimal patient contact that I have. But as far as everyone else, I do believe that it'll impact them. I'm thinking of the nurses and doctors that are being trained. It might make them go a little bit more of the extra mile to make sure everyone is comforted and kind of on the same level. Of course, they always go the extra mile, but now it's just adding another key role. So again, for Amber not being someone who is really in a position where diversity initiatives are going to impact her, that actually didn't make her doubtful or skeptical of their efficacy. Her hope is actually that for doctors and nurses who are going to be the recipients of diversity trainings, initiatives, programming, what have you, that this actually is a positive thing because it has the potential to have a positive impact on patients, even if it doesn't have a positive impact or any kind of impact really on her. And this last quote is from Callie, who is a patient care technician. And I include this quote from Callie because it gives some insight into the experiences that technicians had that indicate why there's such a doubt that these types of initiatives are really going to do much for their work experiences. And Callie told me, okay, so not too long ago, I had this patient and I came to her room to get her baby. It was time to do the baby vitals and to do the PKU, it's the standard test on newborns, on the baby, and her family was in there. Her dad was in there. So when I came in, I did her vitals, and then I asked her, could I take the baby? And I told her I would be back in about 10 minutes. And her dad started going off because she was handing me the baby, and he was like, what are you doing? And she was like, oh, Dad, please, don't start. And she was like, you don't know who she is. She's just coming in here grabbing the baby, and she could be anyone. Look at her. I looked at him, and I'm like, well, here's my badge. My badge had flipped around, so I turned it around, and he was like, that's the problem here. They'll let anyone work here. You people are lucky to be here. Again, this is a pretty stark difference from the types of experiences that I recounted from doctors, although not so much from nurses. For Black technicians, like Black nurses, experiences like these were routine. This was part of going to work as a Black technician. It meant that experiences like these with patients' families, sometimes with nurses, this was commonplace and this was a part of the job. But again, this underscores why for Black technicians, the perspective that diversity initiatives aren't really going to have much of a direct impact on their work outcomes and their work opportunities. It makes sense because diversity initiatives that are focused on nurses and doctors aren't really going to do much to change the experience of having a patient's father who tells you that you're lucky to have the job that you're qualified and trained for. So I want to conclude with a few points. I've argued here that mainstream diversity talk is one example of work transformation in the new economy. We do see organizations being much more likely to talk about saying that they want more diversity, more likely to say that this is something that they value and that they are committed to and that they genuinely want to achieve. But what I've tried to show here is that what diversity actually means to workers, and Black workers in particular, depends heavily on occupational status. What diversity is for doctors is not synonymous with what diversity is for nurses. What it is for nurses is not the same as what it is for technicians. But ultimately, across all of these occupational categories, the types of initiatives that are often in place in hospital settings do not address the racial realities that Black professionals face in the new economy. Those racial realities are driven by both structural and interpersonal factors. They vary by occupation and they have gender dimensions. But ultimately, overall, this aspect of work transformation leaves Black professionals feeling pretty disillusioned and disengaged. Now, because I like to, when I can, end presentations on a high note and not leave people regretting that they invited me because they're depressed, I do want to say that I actually think that there's some room for hope and optimism from these findings. And the reason that I say that is because I think that we are moving into an organizational space where many organizations and many companies, I think, do genuinely want to think about how they can transform to meet the needs of an increasingly diverse workforce. I think that in many cases the problem is that these organizations are doing so based on what they think other organizations are doing, or they are not relying on the literature, or I think as is the case here, they're not relying on the experiences of the people who are actually in their employ. And I think that the fact that many of these workers have been so open and so forthright about exactly what their challenges are and how those challenges get missed by the types of programming that are in place actually serve as a blueprint for many organizations, because I think that they've been very candid in describing the types of structural challenges they face, the types of interpersonal challenges that they face. And I think that presents a map for organizations that are genuinely serious to think about how they can restructure and recast some of their programming and some of their initiatives in ways that better serve the needs of their employees and allow those employees to better serve the needs of the populations that are coming to these hospitals and to these facilities. So I'll stop there. Thank you for your time and attention, and I'm happy to take any questions or comments. Should I just call on people or? Okay. I think there's a microphone. I think there's a microphone coming your way.
Right.
Oh, yeah.
Oh, thanks. I'm already loud. I'm wondering if any of your data, if you saw any kind of themes or come out about this intersection of age and occupational status. It's because medicine is really dominated by white men, and I think I'm wondering if you saw that. That's question one, I guess. And then the second part is the hierarchy of medicine in general. I think what your data is speaking about creates these very specific experiences for Black professionals. And so I guess to end on a positive note, what would be some things as like Black professionals that can be untangled to make sure that the hierarchy is dissolved among Black people to come as a group of Black people to work with each other for the
so dismantling the hierarchy in healthcare
Kind of, yeah.
for Black workers. Yeah, that's
Thank
interesting. I mean, quite honestly, I'm not sure if or how the hierarchy in healthcare itself gets dismantled. If what you're asking is how to promote connections across those hierarchies for Black workers, I think that's possible for organizations with some intentionality, right? It would involve kind of bringing people together, creating opportunities for people to interact in spaces both around work-related objectives and socially and informally. But I'm not sure that I guess I'm kind of skeptical of getting to a place where healthcare itself doesn't have those hierarchies, in part because of the way that it is structured and has been structured, and how entrenched those hierarchies are to how healthcare is communicated and conveyed, at least in the U.S. To the first part of your question, which I think was about age. Yeah, so that didn't emerge as a theme among findings. I did not find that, for example, there were significant age differences among workers, as much so as I found significant differences between occupational categories and gender. Interestingly, and I talk about this in the book, one of the first black doctors that I spoke with was a much older black male doctor who had to have been in his probably late 70s, early 80s when I interviewed him. And in the book, I talk about how I went to the interview kind of really ready because I was like, this guy's gonna have some stories because he's been doing this for a while and he's gonna have some stuff to tell me, and I wanna get some good notes. But interestingly, his response was very similar to what I shared in the program. Despite him kind of being this barrier-breaking person who integrated all of these spaces, he was like, yeah, generally, people have been cool. The problem has been, I couldn't get people were nice, but I couldn't get a mentor who was focused on racial health disparities. Like, I had mentors, but nobody was really adept and had experience in addressing racial issues. There's all these barriers that keep black people out of healthcare and medicine. Like, there's all these structural things that make it harder to get into the field and to stay into the field. And I've been working on those because that's where I've seen more of the challenges. So, yeah, among black workers who were in my sample, there weren't significant thematic differences by age, not nearly as much so as there were, again, very strong ones that emerged and jumped out relative to occupational category and gender within those occupational categories. Yes.
All right, so hello, Dr. Wingfield. All right, so my question is, one of the quotes you gave was that diversity initiatives leave black, I think, physicians indifferent or even annoyed. I'm just wondering, does this kind of trickle down to patients? Like, when we think about healthcare utilization, are we seeing this sort of indifference or this annoyance affect utilization of black patients?
Yeah, that's a fantastic question. So I'm reluctant to answer definitively just because the study wasn't designed to measure causality in that way, right? I mean, I think what you're asking is if healthcare workers are feeling this indifference and annoyance to these initiatives, is that affecting how they are impacting patients? And the study wasn't set up to measure one thing as cause and effect. But what I think we can say is that, especially if we're talking about patients of color and black patients specifically, it is simply a fact that they have different and worse experiences in the healthcare system than do white patients, right? I mean, that's not really even in dispute anymore. That's simply a medical fact. So whether that could be attributed to people being annoyed or aggravated by these types of diversity trainings, I think that there's some possibility there, but I wouldn't want to say without actually looking at data without looking at research that's designed specifically to ask that question. Quite honestly, though, if I were speculating, and I am speculating, but speculatively, I don't know that I think that those types of challenges, they might be exacerbated by those types of trainings, but I don't think that those trainings are a cause, right? I think that for black workers who do experience worse treatment in the healthcare, for black patients who experience worse treatment in the healthcare system, I think that that's quite simply due to racial biases in the environment that we live in, more so than it is to trainings, right? So that I think if you took away those trainings, they wouldn't be a factor in making that treatment worse. I think that negative treatment would still exist even if you compared people people who experienced that training and people who didn't, because I think it's due to factors that are apart from and distinct from that training at large.
Thank you. So I know you mentioned that you focus on the healthcare field, because it's kind of an interesting space that has a lot of these different things happening. And so then I guess kind of it may be speculation again / just kind of thoughts about how maybe some of your findings would connect to other fields, and other experiences that Black people working in other areas might have?
Yeah, yeah. So whenever I talk about this at universities, someone always asks me, do you think there are any parallels to universities? And I think I would say yes, right? I mean, I think that particularly position in the organizational hierarchy, I think, is a factor in what these outcomes and what these experiences look like. But the bigger picture in the story that I try to tell in the book is that I think a part of this problem when we think about the new economy and where organizations fit in it is that the shift to the new economy has meant much more of a focus on profits and financial returns and bottom lines, and that's happened at the same time that organizations have at least tried to say that they want more diversity, right? But I think that those two things kind of collide in ways that mean that many organizations say that they want this outcome, but they don't devote the resources to actually achieving that outcome. And then what happens in that space is that when they are saying that they value this, but they're not actually doubling down on providing the resources and a broad array of factors to create it, what I think ends up happening and what I saw from my respondents is that Black workers step into the gap, right? They actually take up that work. And how they take up that work varies depending on where they're situated in the organizational structure. So if we apply that to academia, I think what we might find is that faculty members would be in a position where, like the Black doctors I described, they may not go into workplaces where they're experiencing overt slights or harassment or kind of this constant daily barrage of people mistreating them, right? But they also might find themselves, we're in a situation where that happens sometimes, right? Occasionally that occurs. But they also are focused on doing additional work mentoring students or mentoring junior faculty or being the people that kind of try to change their departments to make them more welcoming spaces and using the position that they have as faculty to address these structural barriers, right? I think it might be a very different experience for many staff, especially depending on where those staff are located in the university. They might be more along the lines of nurses or technicians, where by virtue of that position, they experience a lot more overt harassment, bias, and mistreatment by being in those positions that would not necessarily be present for faculty, right? But that those staff might also try to use their position to be a sounding board maybe for students or to be available to students and to support students, particularly if they're students of color or first-generation students or what have you, right? So, you know, again, this is not based on, my data focuses on healthcare, it doesn't focus on academia, but working in academia, I think it's safe to say that some of these dynamics of doing this additional work and some of these dynamics of organizations not offering the support that they need to, and what I describe in the book as this process of racial outsourcing, yeah, I think unfortunately that's common among many organizations in this economy today.
Thanks for a wonderful talk, Dr. Wingfield. I'm a geography professor, so I'd like to hear a little bit about some of the locational differences that you might see in some of the broader work. Do you think geography plays a role in any of this here in the United States?
Yeah, that's an interesting question too. And I went in fully expecting to find that as a thematic difference as well, and actually didn't. So one of the points that I make in the book also, in the same chapter on doctors, I talk about a Black woman that I interviewed who lives in a part of the country that's pretty well known for white supremacist activity. Like, this is a thing and it's common there, and that's just part of that area, and it's well known for that being part of that area of the country. And so same with her, when I went to this interview, I was like, oh, this is gonna be a good one, because there's gonna be, you know, just a bunch of material for the book, and it's probably gonna be just completely bonkers. It was just like what I heard from so many other doctors. She had her that one-time experience, but for the most part, she was like, that's not what happens to me every day at work. What happens to me at work is, again, I don't have the support that I need to try to make this a better environment for other Black doctors. I can't get people to come here. I don't have a mentor. There's not the resources. There's not the support from the organization, even though they're saying that this is something that they value. So yeah, surprisingly, I did not find regional variation to be a significant theme, even though, like I said, I went into it fully expecting that that would make a difference. Where I will say that I think there might be some regional variance that I don't talk about quite as much in the book has to do with the extent to which region and place can offer some kind of social support for workers outside of the workplace, right? So, for example, the person that I just mentioned, being in the environment that she isn't around a lot of other Black professional workers at all. Certainly there's no other black doctors where she is, and she's not around a lot of other black professional workers because there aren't any. She's like the one in that town. But for black workers who are in places like New York, Philadelphia, DC, Atlanta, I think being in those environments and being in cities that do have a much larger and much more visible black professional class might offer more of an experience of social support, even if it's not in the workplace itself, than people in other regions might be, or than people in other regions might have. Yeah.
I noticed the examples that you gave for nurses and technicians, like the source of interpersonal hostility. One was sort of internal, right? Other nurses, the first one, right? Can't come to my house. The other one was from like a patient. And was there any sense of like, and what I'm thinking is like, the lower you are in the hierarchy, the more likely patients are going to give you flack, right? Or something like that. Or nurses are kind of in this weird space between doctors and techs, and so they're very sort of status conscious or something. And so, and because it's feminized, they get a little punchy and they punch down, right? So, like, do you see that kind of thing happening? Was there different sources depending upon one's status?
So yes, there were different sources depending on status, and I think it has a lot to do with exactly what you described, right? So, and I thought about this a lot because I was so flummoxed at first and curious about why there were such stark differences between doctors and nurses, right? Particularly, doctors are in this environment, they're so underrepresented, like I showed from the chart. And I think based on the research, we'd expect to have them experiencing much more of that one-time experience, right? We expect that one time to be much more than one time. But I think that status is part of it, but I think it's more so the way that healthcare and medicine is socially organized and consumer-oriented at this point, right? And so when I thought about this more, I thought about kind of how the process of seeing a doctor works, right? Like, so if you have private insurance and you want to see a doctor, the first thing you'll do is figure out who's in your network and who you can actually see, right? But if you're a person where, apologies to you for using you as an example in this way, but if you're a person who's super racist and you're like, I just hate black people and I don't want a black doctor, you can But if you're that person, you can pretty easily avoid having a black doctor, right? You can see who's in your network and you can click out all the black doctors and make sure that you don't see one, right? What you can't necessarily do, though, is have that same level of control over who your nurse is going to be. So if you have weeded out all of your potential black doctors and you found a white doctor that looks like your type of person, and you go in and you go back for your appointment and the first person who comes back there is a nurse, you can't know that up front, but you can be kind of a jerk, right? You can be pretty rude to that person and you can take out your hostility on them. And I think that's a lot of what ends up happening to explain some of these differences between doctors and nurses. I think, again, the status is part of it, but I think the way that healthcare is organized means that people display more consumer choice because there's been more of this, again, model about privatization and consumption in the new economy, and that has implications for how healthcare gets done. And I think that doctors benefit from that in ways that nurses don't. And the thing that really drove this point home to me was thinking about differences within doctors. And I found that emergency medicine doctors' experiences were far different from those of other physicians. They were a lot more likely to have experiences like nurses and technicians. And I think, again, that has to do with how people access emergency medical care, right? You don't pick your ER doctor. You're not at your best anyway if you're at the ER, but you also get whoever happens to be on site, and you don't get to exercise that advanced choice in consumerism. And I think that has a lot to do with why those doctors were like, no, people are completely out of control and they use racial slurs and I just deal with everything because that's just what you get. And I think their experiences were more parallel to nurses and technicians that way.
So I was thinking about the overrepresentation of Indian doctors and Middle Eastern doctors, and I was wondering if you think the findings of this study would be similar if you were looking at those demographics, or would they get a pass because of their model minority status?
Yeah, I'm sorry. I thought.
And sorry, I have another question. It was more so about how Middle Eastern people have to document that they're white on applications, and if you could talk about how this is problematic for that demographic.
Okay. Now I will answer the question now that you put the mic down and I'm sure you're done. Yeah, that's an interesting question. There is some research that does look at doctors who are South Indian and the experiences that they have in the healthcare profession. And I think Lada Murti has an article on this, and I can't think of the other author's first name, but the last name for the citation is Bhatt, B-H-A-T-T. And both of those articles document this process of kind of what you're describing, that kind of intermediary experience, where particularly if they are darker skinned doctors, there are often presumptions and doubts that people have, or assumptions that people make about where they're actually from that are in many cases inaccurate. But they also seem to have more ability to prove themselves as people who belong by relying on credentialing, right? So having your white coat, or having your badge, or having your name ID, those things function more as symbols that reinforce legitimacy in ways that seem to be easier for them to do than for some of the Black healthcare workers that I spoke with. So I don't know the extent to which that changes the overall experience that I'm describing. Like if you have a greater ease of legitimacy, does that mean that you are more or less likely to do this equity work? Are you more or less likely to feel disillusioned and disengaged by these types of diversity initiatives? I'm not sure, and I would want to, again, have a study that focused on actually testing that to try to know for sure. But I do know that, again, we do have work that does show that there are those differences present for those healthcare workers. And your second question, I think, was about Middle Eastern and North African workers being classified as white, which, yeah, I mean, just from a standpoint of what we know in the research on race and inequality, obviously is overtly misleading and misguided, but it also functions, if you're misrepresenting people, or misrepresenting or pushing people to misrepresent their racial identity, then there are a lot of consequences to that are adverse. And if that's a requirement from an organizational standpoint, then that doesn't necessarily, I think, send the message that many organizations say that they want to about their goals and expectations around diversity. Oh, there's.
I was kind of just curious about in some of these discussions or interviews, the interplay of queer or trans folk and those violences seen with racial schemas or in those systems. I understand that there might be a gap there due to forms of representation, or even just forms of representation. So maybe even just the conflicts between Black male nurses having a hyper masculinized image, and then being a nurse, so it's oh, you're gay, or you have to be more feminine to make sense of their position.
Mm-hmm. Yeah, that's another really great question. So this project doesn't focus on that as much, but I actually have some previous research where I did focus specifically on Black men working in nursing, in part because I was motivated by trying to think through those exact questions, right? How Black men, what being in both the racial and gender minority meant for Black men working in this culturally white, feminized occupation, how they dealt with some of the assumptions and stereotypes around sexual identity and what that meant for them in that profession. So the research that I was operating from that is out there that focuses on men working in nursing in particular and more culturally feminized occupations suggests that part of how men navigate those environments is by distancing themselves from the femininity associated with their jobs, trying to be very hypermasculine, trying to bond and spend time with other men in the profession, even if they are in higher status positions. Interestingly, that's not what I found for Black men in my work on Black men nurses. I found that they actually weren't very prone to or focused on trying to distance themselves from ideas of femininity. They were more likely to say that that didn't matter, and they would recast actually ideals of masculinity as being grounded in being comfortable basically not being defined by those stereotypes, right? So things like, I don't care what people think about me being a nurse, and it actually makes me more of a man that I'm not someone who's just trying to follow these stereotypes. It makes me more of a man that I'm focused on healing and caring for my community and helping to improve health outcomes and doing things like that. So yeah, for those respondents, those intersections certainly affected them, right? But they were a lot less likely to follow the path that we see present among white men working in those professions, and actually more likely to create really new and distinctive pathways towards how they wanted to embody and understand their work in a culturally feminized profession. Again, including not being subject to stereotypes and assumptions that people made about sexual identity, about femininity, and not really, just basically not buying into that as a strategy for doing the work effectively and focusing on why the work itself mattered more.
We have a question for you online.
Oh, okay.
So from Mr. Eric Scrimshaw, excuse me if I pronounce that okay. As a professor of medicine, while I am not surprised to hear that nurses experience racist comments from patients, I am really appalled at the comments that nurses experience from their colleagues. Now question, did Dr. Wingfield get a sense of why nurses tolerated this? Did they report these comments? And what were the barriers to reporting? Also, or did they report and found it to be counterproductive, maybe retaliation or inaction?
Yeah, so that's a great question also. And from most of the nurses that I spoke with, there was deep, profound mistrust of the organizations where they were employed, right? So I'm trying to think of examples of people who reported these types of issues. And most people didn't report them outright, which is to say that these issues became present, but they became present because they escalated, and often the nurses had to defend themselves, right? So they dealt with these things from their colleagues when colleagues kept kind of saying they were doing things that they weren't, or accusing them of doing things that they weren't, or making things up or what have you, and eventually things would get to the point where they'd have to say, no, I didn't come to work late. You can see where I clocked in. No, I didn't, not deliver this baby because I was out of the hospital on my coffee break. I was actually with another patient. But most of the nurses in my sample did not feel that they had the support and the backing of the organizations where they were employed enough to feel a sense of trust that they could report these issues, and that if they did report these issues, they would get treated fairly. That was not present among my sample.
Thank you.
Mm-hmm.
Thank you for your talk. I was hoping that you could talk a little bit more about the methodological process, the data collection. You did so many interviews, how you recruited participants, and especially for the graduate students here who might be designing research projects themselves.
Yeah, that's a fun story. So, and the reason I say that, I don't know if I'm advising this per se, but I will say that in my own experience, given that the populations that I study sometimes can be hard to reach, I've found, quite honestly, like it helps to have no shame at all in trying to reach people. And what that's meant has been some odd choices in my life about just like times and things that I've done to try to recruit people for interviews. So I mentioned the study on black nurses. This was a while ago when I did that study, but that was a real challenge in finding respondents. Black men are 2% of nurses in the population, period, right? And that's actually rounding up from 1.8. They are not an easy population to access. And I knew that when I started the study, but I was like, I gotta find these guys because I have this research question, I wanna answer it. So I remember when I was starting this project, I was at home, this is when I still lived in Atlanta, I was at Georgia State. I was at home and I was fooling around on my computer, and I somehow came across this, the Black Nurses Association. And it turned out they were actually having their meeting in downtown Atlanta, and they were having, I think the last day of the meeting was the same day that I was looking this up. So I was like, you know what, I'm doing it. So I got in my car, I drove downtown to this hotel, and I literally hung around in this lobby kind of trolling for nurses. So I looked for basically anybody who had on a name badge who looked black and looked like they were a man, and I was like, hey,
You look like a nurse.
yeah, like I know this is super weird. I'm a researcher, I work at this university. I know this is extremely odd. I got my card, I'm legit. I'm not completely crazy, but I'm doing this research study. And, I'd really appreciate it if you might be willing to give me a little bit of your time just to, interview you and find out more about what your experiences have been like. Again, it's embarrassing to recount that in a public forum, but it worked. And that was how my sample got started. I met several of my respondents that way. They referred me to other people who were part of the study. So usually what I've tried to do, professional associations are a godsend. Those are really helpful, and those are usually a place that I try to incorporate in terms of reaching out for people. I'll use professional connections if I have them, and usually there's somebody that I know somewhere who can give me a start into finding someone. For this particular project, doctors and nurses were fairly easy to access, in part because I had the connections from my earlier project. Technicians were the hardest, and I think a lot of that just had to do with their schedule and their time. This was another place where I did some weird stuff. When I was in the hospital after having my second daughter, one of the technicians was a black woman, and my husband was like, "You're not gonna do this." And I was like, I am gonna do this. I'm doing it, I'm totally asking her. I feel like she thought it was super weird. She did not participate, but she did point me towards some other people, and I found some respondents based on her kindly giving me some colleagues' information. So that's what I mean when I say, again, when I say these out loud, I know that's incredibly odd and bizarre, but it worked, and it got me the sample that I needed, and it got the book published. So, yeah. Thank you.
Okay, I'm ready. Can you talk a little bit about these ineffective diversity initiatives and what they look like so that maybe some of us can stop supporting them?
About ineffective ones, you said, right? Ones that are not effective?
Yeah, because throughout you're talking about, the diversity initiatives, but I wondered if you could just kind of explain what they do look like, and so that maybe we could stop supporting these kind of things.
Absolutely. So one of the most common ones that I rail against whenever there's an opportunity, and I talked about this some here, is just how much mandatory diversity trainings do not work. And I feel like it's important to reiterate that because they are so common and they are so ubiquitous and they are used so many times and in so many places and by so many different industries. And there's actual data to show they do not work. If we're talking about actually improving the numbers of people of color, of white women in organizations and management and leadership roles, diversity trainings will not get that done. And there are a number of reasons why. But in a nutshell, the shortest reasons are that, one, when you are requiring people's compliance, people are less likely to be receptive to what you are requiring them to do. So for many white workers, they feel like I'm being forced to do this thing where implicitly I'm getting the message that I'm the bad guy and I'm doing something wrong. I'm not even open to hearing this. For black workers, they feel like this is also a stupid and pointless waste of my time. The issues that I actually have are not getting addressed by this initiative, and here's another environment where I have to go and kind of be in this space and feel uncomfortable and not feel good about what's happening here, right? So I don't know if anybody watches The Office, but there's this episode from The Office where when they do sexual harassment training, Pam is like, whenever we have sexual harassment training, everybody sexually harasses me. That's kind of a parallel to what happens with diversity training, right? People do not feel like this is the best use of their time and they're not inclined to really do what it says that it's supposed to do. So those types of trainings are not really helpful. In terms of what we do know that actually is more efficient, having formalized mentoring programs can be more useful. Those are shown to increase, if we're talking about corporate and private sector organizations, those increase the numbers, I think, of black women in leadership positions somewhat modestly, but not necessarily for people of other racial or gender groups. What the research does show is most efficient, though, is actually, one, having people who are diversity officers or managers who have resources and support and the backing of leadership and organizations to actually do the work that they're doing. Actually having diversity committees in departments and in sections of an organization that pull from a cross-section of people in the organization. So at a university, having a diversity committee in a department that's not just faculty or not just senior faculty, but junior faculty, staff, graduate students, postdocs, undergraduates, pulling that cross-section of people and empowering those people to actually come up with solutions for the issues that are present actually does a lot. And the reason why is that researchers find that when people are in a position where, and again, if you don't mind using as my example once more, if you're in a position where, so if you're in a position where you follow the diversity training model and someone comes in from outside who's a consultant who doesn't know the organization quite as well, and they say, here are all the things that can go wrong, and here are the ways that you need to be on guard because otherwise you'll get sued, and here are the ways that you could potentially be a problem. Probably you're not going to be very receptive to that. But if you come together with colleagues and you're told, okay, our job is to figure out where the problems are, but also to diagnose the solutions, that puts you in a position where you're more likely to feel like you have the autonomy and control to be a part of something constructive. And just basic social psychology suggests that that's going to make people more receptive to wanting to implement and advance change than being told that they're doing something wrong and they're part of the problem, even if they are doing something wrong, right? So there's actually a book coming out, it might be out now, by Frank Dobbin and Sandra Calof called Getting to Diversity. I think it just came out, but I would highly recommend it because it does spell out in a lot of detail many of the ways that organizations make very common mistakes, like these diversity trainings, and many of the things that are shown through data and research to be more effective solutions and help organizations avoid kind of falling back into those pitfalls.
Hi, I have another question. So for a group of sociologists, everything that you explained kind of makes sense, but I guess I'm wondering, what are some practical tips that you have for us to take back to the institution of medicine and basically people that are in leadership roles that can change or do something about your findings, put them in practice, change things?
Yeah, that's a great question too. I mean, I think if you're in a healthcare space, which it sounds like you are, one of the things that I took away from this research was that it did seem like healthcare as an industry really does want to make some of these changes, right? I think in this particular industry, what seems more present to me is a gap between kind of the knowledge of what works and the will to actually enact it, right? So it strikes me as a place where people want to make these changes, they just don't necessarily know what they should be doing, so they rely on cultural competence training because that's a common, easy thing, right? So workplaces are going to be different, organizations are going to be different, but I think the first broad step that I suggest is really getting a sense from the people who are in the organization of what their experiences are and have been, right? For healthcare facilities, this work is a blueprint, I think, of some of the things that I've found. But I would just encourage people to take the pulse of your organization, right? What is happening there? What are the challenges that people are experiencing? What do they say they are dealing with? Where do they say that they feel stifled or constrained or restricted, right? What experiences, what aren't they saying to people about their experiences if they're nurses? What aren't they dealing with, or what aren't they talking about publicly if they're doctors or technicians, right? So I think taking the pulse first of where the organization stands is the first step. And then I think the second step is really just to enact policy to the extent possible that reflects that, right? And to make sure that if organizations are putting into place policies where if organizations are either putting into place or by virtue of inactivity leaving norms in place that can be detrimental and harmful to workers of color, think about how they can possibly change that, right? One of the questions that I often get from people with the example, the last one that I raise of Callie, the technician, and the patient's family, right? Sometimes when I talk to people in medical spaces, they'll say, well, what can we do about that? Patients say what they say, and, we can't really control for what patients are going to say to our workers. But I don't agree with that. I think you can. And I think there's a responsibility that organizations have. If they say that they want to be these places that are going to be more attuned to diversity, you do have a responsibility to your workers. And your responsibility is to make sure that your workers don't come to work to get racially harassed. That's not acceptable. And that's not okay if you're an organization that says that this is something that matters to you. So you might have to think about what standards you want to consider acceptable for your patients, right? Is it okay and fair to say to patients, you can't racially abuse and harass the people who work here, and you won't get treatment here if you do that? I think that's a step to consider, and I know that there are healthcare facilities that have taken that step, and that's been a thing that they've said in response to issues exactly like this. So I think the step is to think about and to find out, practically speaking and with data, what are your employees dealing with? What are they experiencing? What do these experiences look like? And then to think about, now that we know this, if we're going to say that we're going to be this place where we want to serve all people and we want to be a diverse organization and we want to care about the employees that we have, what does that mean concretely and from a policy standpoint in terms of what they experience when they come to work, what they deal with when they are at work, when they leave to go out of here? How do we make sure that we're constructing this organizational space in such a way that we have their needs in mind and that their concerns are heard and welcomed and validated? And it cannot mean doing more of the same thing, because that's not a viable option. Because if it were, I wouldn't have had this project, right? I just wouldn't have gotten the data that I have and heard from people what I did.
Thank you so much for your talk. I wanted to follow up on Shannon's question about methodology. Totally appreciate the tip about just get creative and innovative and a little crazy, and that works a lot of times, right? I was curious about your field observations and how you gained access to these situations and people who allowed you to shadow, how you negotiated HIPAA, given that you were, I assume, shadowing and they were visiting patients and things like that. Could you say a little bit more about that? Were they interviewees that you were able to then connect to?
Yeah, that was an interesting process also. But yeah, the 3 people that I shadowed were also people that I interviewed. And so they were very gracious and agreeable about letting me spend time pretty much shadowing them at their workplaces. As far as regulatory requirements, so because I had to get IRB to approve it also, for IRB, they were fine with it as long as the focus of my work was on the practitioners and not on the patients. So no patient data was included in the study, and I wasn't even, the focus was not even on kind of patients and patient data. It was much more so, what are your regular interactions, like what's your workplace like, and what are you doing on a daily basis, but nothing related to kind of actual diagnostic stuff with patients made it into the work at all, because that wasn't the focus. I do have some accounts of interactions that doctors had with patients, but again, the focus was not on anything that could in any way compromise patients' privacy around their particular healthcare concerns or issues. So I think part of the relative ease that I had with respondents in terms of their agreeability to spending time with them, I think some of that also was reflective of the population that I was focusing on. One of the things that I learned in shadowing these healthcare workers is that doctors are kind of in this weird position where someone asking to kind of trail along behind you and observe you, that's actually not that unusual in ways that I think it probably is for many other jobs, right? Like, to me, that'd be super weird if someone was like, hey, can I just trail around you, trail behind you all day and watch you type on your computer? No, that's weird. Get out of here, right? But for doctors, it's not like that. Interested students want to follow them. They're used to doing rounds. They're used to taking people around and, interacting with patients and having people follow them. So I think that contributed to their comfort and familiarity with me being yet another person who was just part of the band of people traipsing around behind them with a notepad and following them and, writing down what they were doing and what they were saying. But generally, I think the project could have been done with just interviews alone. I didn't have to do the field observations, but I think it really added a lot to it by giving that additional kind of data point and window into how what they described either was or wasn't reflected by what they actually did and what I actually saw in following them during the time that I spent time with them. So yeah, I think it was really useful. It taught me, as my sister put it, I picked the right kind of doctor to be, because I don't at all have the stamina or stomach for doing that on a daily basis. It's just not, it could not be me. But again, as an observer and as a sociologist and a social scientist, I think it really was useful in contextualizing a lot of the interview data that I got.
Could I follow up with just,
Yeah.
how did you present yourself then? Did you have a lab coat on? Did you present yourself as a researcher, or as just somebody who's tagging along?
Yeah, so I did have a lab coat, which I actually really liked wearing a lot. I very much liked that. And I'm pretty sure I got special treatment at a Subway across the street from the hospital, because I came in and forgot I was wearing the coat and got access to a restricted area that I don't think I was supposed to be in. I think that was totally because I had the coat on, which I was very happy about. But yeah, so I did have the coat, and the workers would always introduce me as someone who was following them for a research project. And I forgot to mention this before, but part of the thing with patients, obviously, if they didn't want me in there, then they could just, they had to say it was fine for me to stay. And if they didn't want me, I was totally happy to leave and just wait outside. But no patients did. And again, I think, I've been on the other side of this equation. I've been a patient in the doctor's office. I've been a patient in the hospital. People come in, especially in the hospital, really, I just want all of you to leave. So one extra person in the room doesn't really matter, because you're all kind of in my space and I want to go home. And I think that's how many of the respondents dealt with me being in there, that there's just one more extra person that I don't know when I want to just wrap this up and be on my way. Thank you. Thanks, everyone.